Thank you for having me join this discussion and share some of my work in thinking around computable phenotypes. In this talk, I hope you'll be able to define the term computable phenotype if you're not familiar with it already, and discuss the relevance of computable phenotypes and phenotyping to pragmatic clinical trials. I hope we'll be able to discuss approaches to finding existing phenotypes and to assess their quality and appropriateness for certain uses, as well as to discuss the importance of reporting phenotype definition features and data quality assessment for pragmatic research. And I think you'll find through these objectives, I'll be echoing some of the past talks that you've had in your laboratory and network. So I'll talk largely from my experience with NIH Pragmatic Trials Collaboratory and my experience with informatics and electronic health records for research purposes. I'll talk about computable phenotypes and how they're used in some of our studies in the Pragmatic Trials Collaboratory, and then talk more broadly about how you can find and assess existing phenotypes for reuse. And then I hope our discussion can really move us toward the building future infrastructure and collaborations that can help optimize the use of phenotyping in the LeaRRn network for your very important research. So if you're not familiar, I would refer you to previous Grand Rounds. You had a wonderful lecture by Julie Fritz talking about pragmatic clinical trials. And so pragmatic clinical trials are essentially investigations that are embedded in healthcare systems, and they are designed to increase the efficiency of research and relevance to clinical practice. And one defining feature, almost a defining feature, is that these use existing data and most often EHR data as part of to collect the research data. So rather than a new stream of research data, these trials maximize, pragmatically so, existing data sources. So as you might be familiar with, the NIH Pragmatic Trials Collaboratory is just over 10 years old. And this program, through a number of demonstration projects, is building our national capacity to implement cost-effective and large-scale research studies and help future researchers to be able to develop pragmatic trials that can reflect generalizable patient populations and that can address pressing research questions. The NIH Collaboratory has sponsored and worked with 22 demonstration projects. Some are completed and some are active. You might recognize to the top right, the Beat Pain Utah study, which you've heard about in previous talks. These studies cover everything from infection control to chronic pain management, management of post-traumatic stress disorder, or kidney disease and dialysis. So just a range of questions and topics. They're sponsored by many different NIH institutes, and they all have a planning phase and then an actual study phase. And so a centralized coordinating center supports a number of methods focused cores. And these cores are listed here. I co-chair the electronic health records core, which coincidentally used to be the phenotyping core, and then it was the phenotyping and data quality core, and now we've broadened. There's a number of other cores, and these cores work with the demonstration projects and really develop strategies to problems that emerge and sort of summarize lessons learned. So my role and my privilege with this network has actually been to just observe these multiple studies and identify challenges and common challenges and solutions for them. So I'll be sharing some of my work there. As part of the EHR core, we were continuously looking at how are people using EHRs, and in particular phenotype definitions, which I'll describe more formally in a moment. So you'll see that in gray is how these different trials are using the EHR. In the left column, you'll see that most studies are using EHR data to determine eligibility for the study. To move to the middle column, several, not a majority, but a good number of studies are also using EHR systems to actually deliver the intervention. And then almost all studies are using EHR data as the outcome assessment. And the one exception here that stands out is the primer. They're actually using claims data to evaluate their outcome. What we found from looking at all these different uses of EHRs in a number of pragmatic clinical trials is that no two EHRs are alike. Even when they're part of the same commercial system, there's differences. There's difference in local codes, how people choose to represent those codes. And so shown on this table just shows the variety of lab result units that were found in a number of sites in the mini Sentinel FDA project. And this is just typical of what we see. And so to fix this, to address this, really requires engagement of local experts, so people that understand the data at each site. And this takes time. And the more sites you have, the more work is involved to sort of do this investigation and this cleanup and harmonization, if you will, and just to understand that. So that is something that all our projects have experienced. We've also experienced no two EHRs are alike, even if they're from the same vendor system, just in terms of the functions that they support. So this example is a registry reporting function that comes with the EHR, and one of our investigators found that different sites actually used it differently. So it had implications for how they got data and how they design studies. And again, the idea is that these EHR systems are customized by individual site. I know this has come up in your previous talks, and local adaptation is necessary, and this takes time. It takes time by people on the ground in each of the sites. So it's not a central data person, but a data person that's very familiar with the particular EHR system and their implementation at a given site. It's also important to note that the EHR is optimized for billing. So the data that's available, the code systems that are used most widely are those that have a requirement for billing. And so integrating research sort of data elements into the EHR can have some implications for the clinical workflow. It can also requires scarce IT resources that are a challenge. And the primary reason that EHRs exist is to support the business aspects of a health system, and research is secondary. So EHRs are just beginning to evolve some of these functions, and we're highlighting some of those in the NIH Collaboratory, and I know your group will find them as well. Challenges and opportunities to sort of enable our systems and the data that we collect in health systems to support important research. And engaging health system decision makers is critical for to make these kinds of changes. The EHR core has done a lot of thinking and a lot of just sort of descriptive papers on how we use phenotypes and EHR data more broadly in our studies. So I'll point to those. So my background is informatics, and a lot of us on the EHR core share that background. So we tend to target towards informatics journals, but we've got some general recommendations that are important really to all aspects of the trial, not just the informatics. But the first is engaging systems as research partners to access local IT staff. Frequent communication among staff and research teams has been reported as just essential by all of our completed projects. All of our studies have suggested that systematic data quality tests throughout the study were critical. And so as you're planning new studies, thinking about building this into your budget and your timeline, because it is essential. The use and development of standards to augment EHR systems. We pointed out that EHR systems tend not to have all the elements that people need for a given research study. And so there's a need to usually collect at least some minimal level of data. And if this is the case, we really encourage people to identify elements from a standard library, share what you're doing, really build a culture of sharing and reuse so that we can minimize the variation and move towards standards that will enable us to have more multi-site studies in the future. So I've gotten this far without defining a computable phenotype, so let me do that now. Phenotypes are specifications for identifying patients or populations with a given characteristic or condition of interest using data that are routinely collected in EHRs or ancillary data sources. So I really sum it up as an EHR-based condition definition. And sometimes it goes a little beyond the condition definition itself. Sometimes other eligibility criteria or sort of administrative elements are thrown in. That we can think of these as computable phenotypes as EHR-based definitions for conditions. And one example here is diabetes. And I just want to show you this definition includes a couple of different data types and some logic and some values. So I hope you can just sort of see highlighted. I've got ICD codes in the top line. So this definition includes one inpatient discharge diagnosis of any of these codes that are listed, or a combination of any two of the following events occurring within 24 months of each other. And we've got some labs listed and some medications. So these can be multi-data type. There's some logic, there's lists of codes. So this is sort of what a standard rule-based phenotype definition looks like. And these are used, as I described, in all different phases of research, from identifying your eligibility to specific covariates to outcomes in some cases. And so I'm hoping to open your eyes and introduce the concept that this need to be more explicit about these definitions. So when you review published research and you look at the table, your table 1, you'll see your characteristics of participants. And so the question is, there's a lot of ways, for example, that diabetes or history of diabetes could be determined. So I showed you one example. There's other definitions that are used in registries and research studies. You could have a purely lab-based definition. You could use with multiple elements or just one, and you could include diagnoses. So knowing this information is really important to assess the trial and the quality, the relevance of that trial to patients in your setting. And it's also necessary to replicate those studies or implement the new interventions that are perhaps screening for this if this is part of the eligibility. So there is definitely a case to be made for being explicit. And if we could reduce the number of these that are used in research, that would, I think, just sort of intuitively, there'd be some benefits there. Let me just highlight a few of the benefits I see about sharing and reusing phenotypes. They can support the development and conduct of new multi-site studies. There's a lot of efficiencies in being able to share that code. And I'll give you a few examples of where we lack infrastructure to sort of optimize that. The ability to compare 2 different data sets, 2 different studies, and to facilitate the reporting of data sets or trial results to clinicaltrials.gov, or as I showed earlier, this preparing and presenting the research in actual publications. Finally, just to sort of give a bigger context that I know we're all in this audience very interested in learning health systems, this idea of research influences practice and practice influences research, to me, just right at the center, I feel like reusable definitions, the same patient population definitions that we see in research, we want to be able to apply those to relevant populations in our settings, and then share what we learn, report that back out. And so I think explicit and a shared definition between research and practice and other aspects of the learning health system, moving knowledge into practice and practice back into data and knowledge, just sort of hinges on having certainly explicit and also similar phenotype definitions. So that's where I'm coming from on this. And now I want to spend the rest of my time talking through sort of how do you find and reuse these phenotypes. So I see a number of steps involved in reuse. The first was finding, and then we'll move down the list to, you've got to assess it, implement it, validate it in your populations, report, and publish your study. And so there's a process here. So I'll highlight each of these. So first, where can I find phenotype definitions? There's a number of sources. I think one easy, quick source for many, but it won't get you everything you need, is the Chronic Conditions Warehouse, which is supported by CMS to support research using those data sets. And so there's a number of condition definitions. This has been a resource for a number of years. It's very mature and focused on chronic conditions. So you won't find everything you need here, but just as an example, I searched Alzheimer's disease, and here's an example of what you might find. So there's a reference period, there's the number of types of claims. So these are using claims data, but you still have your diagnoses there. So these are using ICD-10 codes. Tells you how many, it's an inpatient or a skilled nursing facility. So there's some logic in here, but it's narrative, right? Some logic, some code, some narrative. So that's an example. The PKB, Phenotype Knowledge Base, if we were all in person, I would ask for a show of hands of how many people are familiar with this. This is a resource that has been around for a number of years. It emerged from the eMERGE genetic studies, and a number of academic medical centers with fairly mature EHRs wanted to work on multi-site trials for phenome-wide association studies and to share that. So, and then they've opened it up to be public. So the Phenotype Knowledge Base is PKB. If you're not familiar with it, I encourage you to go give it a look. You can see a number of phenotypes in there. It's still limited. So I think maybe there's 100 phenotype definitions in there. So, but this just gives you a flavor of it. And you can select a phenotype, and as you dig in, it will give you some, you've got data dictionaries. There's some statistics here in terms of the performance metrics. The population of that data is variable. There's not necessarily a requirement for validation study protocols or that type of thing, but there's a place. Files can be posted and people can certainly share information, and it can be searched in a number of different ways. So definitely a good resource and really speaks to the need of the phenotype sharing platform. So look at that. And then more recently, the HDR, which is the Health Data Research Alliance out of the UK, this is supporting their national research programs. They have recently put forward a phenotype library that has over 791 phenotypes right now. And so just to give you a flavor of that, I haven't used this extensively myself, but it would certainly be on my list of places to look at, because what you have is I just searched dementias, which is what's highlighted in yellow. So you have a name of a phenotype definition, a code number for that definition, and some information on the left about the coding systems used, the data source, date, authorship. These are sort of important things to know. If you look in the content page here, in the gray, you see read codes version 2. So that's a coding system. So we don't use that in the US, but it's specified here. You could dig down further and find out what the codes are. So there's a public face and ability to get some of this information. If you dig down onto one of the dementia phenotypes, which I just grabbed just for illustration purposes, it gives you a narrative definition of the intent of it, and some of the logic, and then some implementation details so people can post information and code that could be shared. There's, again, some more specifics, but also publications I wanted to point out. And on the left, you can see some of the features that they offer. So publications, the access to clinical codes list, API, application program interfaces, so ways that you can sort of get at these codes. So this is making things a little bit more accessible in terms of information, and I think it's a resource to really watch and consider. Finally, I want to mention the Odyssey network. And again, I would do a show of hands if we were live together to see how many people have heard about this, because this is a really active and growing observational research community. They're developing standards for harmonizing data and methods. So I know Jacob Keane mentioned common data models and OMOP common data models. So this group is doing a lot of work in this area and sharing their experience. So they actually have a page that says Phenotype Library. So I always start, each year kind of searching on phenotype libraries to see if there's any out there. And this one basically says sort of coming soon. There's code posted in different GitHub sites all over. There's definitely a spirit of sharing, but there's just not a searchable platform here yet, although I do believe it's coming. What Odyssey does offer, and I'll direct you again to the resources and to this site, they do something they started last year called Phenotype February, and each day of the month they look closely at one phenotype and sort of explore and try and test different definitions and sort of understand what's going on. So it's a very narrative blog type format for each of these, each condition, and there's some great information, and it just sort of highlights the state of the art of where we are. So I'm going to share the Phenotype February Day 5 just briefly, and hopefully it's enough of a teaser to get you over there to look at the site yourself. But anyway, in this, Patrick Ryan, who's a statistician and epidemiologist, I believe, very active in building Odyssey infrastructure and tools, shares his experience with looking for Alzheimer's disease. And first, I love this, that he starts his journey, his description of his journey to us, saying, well, the first thing he did was look for phenotype definitions. And this is exactly what we did in the early days of the Collaboratory for every study. We tried to define a standard approach for this. Phenotype and computable phenotype and EHR condition definition are not mesh terms, and they're not searchable terms. So Patrick shared his search. And while I'm talking through this, I want to ask you how many results you think were returned. But first, he had to search on the condition. So there are mesh terms or variations of mesh terms and keywords that you could use to identify what your condition is. Sort of want to look at the type of study that you're doing, or where you think you might find phenotype definitions that would be useful. So epidemiology studies or registries, for example, and then more specifics on the type of database that you're looking at. And then he was filtering out non-observational research for his needs. But anyway, just an example of the complexity of a query you might do. There's lots of ORs in here, so this was meant to be a very broad query, and I'll share that he found over 1,000 results, right? So then you have to sift through to see. And of those thousands results, he narrowed down and he found three or four different definitions and shared them here. I'll highlight, I know the print is small. Basically, these all use ICD codes at different intervals, 3 years, 1 and 3 years. There's different sets of codes. There's some specifics about what type of claim and how many visits are there, but it's narrative, right? In another paper he again found narrative, but this time more like an image, right? So the codes are listed here. And then there's additional information in the text of the paper that might provide information on the definition that's used, but not in any kind of way that's sort of grabbable, if you will. And he ends with this sort of statement, his challenge was, how do you assimilate all this? You do a search, you find different phenotype definitions with different code list formats, different lists of codes. And the questions become, what are the differences between these? And are they impactful? Like, how would you choose one definition over another? And we just don't have a platform or tools for that right now. Through the Odyssey network, Patrick and many, many others are working on tools. And their approach is to build sort of a concept set using a broader vocabulary called SNOMED CT that groups things and is a way of pulling together lots of ICD-9 and 10 codes. And they do a lot of iteration, as you can imagine, and a lot of testing and review. And they're testing around their data that is accessible from multiple sites. So again, they have a common data model, as Jacob mentioned in a previous talk. So there's some challenges in the real world that are difficult. These tools may be useful, but there's just a lot of work to do to look at all these different sites and think about how we would apply all these different things that we're seeing in the literature. So a big challenge. And just to sort of summarize sources of phenotypes, published literature, research networks, no doubt there's a lot of sharing in very disease specific networks and in collaboration. So that's a great source. In terms of national, I've highlighted a few federal sources. The National Library of Medicine USAC Value Set Authority Center it provides lists that are used for quality measurement, so lists of codes that would reflect diabetes, lots and lots of conditions. There's thousands of those on there, so that's a resource. There's a lot available in GitHub. People are sharing, it's just not easily searchable. And then the enhanced code repositories, I would put Odyssey in that group. And then sort of national or just multi-disease phenotype repositories are still new and incomplete relatively, but I would point you to FACMI and HDR as sources of those. So now you've gone through all that and you've found a phenotype, or maybe you just did a consult and a colleague gave you a phenotype. Then the next question is, how do you assess that? How do you even decide if it's usable? And I love to point to this. This was a thesis, a master's thesis done by Blake Cameron from Duke a number of years ago, still very relevant. He developed a user's guide to computable phenotypes, just to help in that question, do you buy or do you build? Very readable, so I'll provide the link in the resources there. He offers some ways to think about criteria. First, sort of overall criteria, who, what, where, when, why. Like, who is this meant to address? Which patients is this meant to identify? What is it? Where is it implemented? When and why, right? So those basics, and a lot of different people could evaluate those. But then there's also two different criteria, and he really makes the case, and I hope this diagram shows, this is from his thesis, that there's some questions, the clinical questions are important. You need a researcher or a clinical expert to determine, is this algorithm valid in my patient population for my intended purpose? And then there's a technical component too, which is just, can we do this? Does this require natural language processing? Do I have that ability? Is the documentation quality clear? Can I find the list of codes? Those types of things just speak to technical readiness. So I think those are all things to just sort of keep in mind, that this is a multiplayer game in terms of determining the fitness. I want to highlight Laura Wiley, who's a new researcher at University of Colorado, who's done a lot of work in this, and her research echoes some of what I've been sharing, and she's providing evidence about this. So she's done a number of reviews of the literature to determine what's reported, and then within specific areas, she's working in heart failure to look at differences between the definitions, and if there's even a potential for bias and disparity if one condition, for example, calls on or relies on codes that might be more likely to be applied to or represent procedures that would be more likely for men as opposed to women, for example, right? And that can have downstream implications, serious ones on the research and the outcomes. So she's done a number of literature reviews. They're still preprint stage, but she really summarizes all her great work first to say there is no standard reporting of the information you need. It's just not typically available in publications. But that, as a researcher, what we want to find is, does this phenotype algorithm, does it capture the right patients, from my perspective of what I want to do? And does it have the performance metrics that I need? So let me move on. Okay, so now we've thinking again of assessing. We're going to come back to, the purpose is really important. And then what are the performance metrics? And again, what are your needs? So do you need a high sensitivity definition? Is it more important to cast a broad net for, say, an educational program or a study screening? And then are there cases that you need to really hone in on the specificity or the positive predictive value? And there's trade-offs for each. Then implementation is the next step. Is the documentation clear? Do you have the required data? Is the data formatted correctly? And do you have the capability to do this, as I mentioned before? Validation approach is tough. So first I'll say we always come back to some measures, and there's a trade-off between what you need. What's more important, high sensitivity or high specificity? Sensitivity is and specificity are sort of less frequently reported. Those take time and resources to evaluate. You need a gold standard, which I'll mention in a minute. So you've got some sort of logistical constraints, and you need to think through what metrics are most important for you and what kind of capability do you have in terms of validation. This is a busy small print diagram, but I want to just mention that phenotype evaluation it's a rigorous process. It really requires a protocol, and again requires multidisciplinary experts. So Shelley Rusinkovich from Duke made this a number of years ago, early on the PCORnet days, to sort of highlight that there's sort of technical and clinical people involved. So the blue is the informatics or statistical sort of activities, and then the green is the clinician-led activities. And the key is that if you're going to truly validate a phenotype, you need to have a gold standard, and you develop a process, for that gold standard. It will be most likely a chart review conducted by clinical experts. So you need to define those experts, define the methods for the review, develop a database, and then you compute these performance characteristics. So it really is, it's an important process, and it really should be systematic and structured and require multiple people. So I highlight that as just an overview. And I hinted about the validation. So you always want to validate against some standard, and ideally the gold standard really is this sort of manual review of patient records. That's expensive, time consuming, and difficult to do in many cases. So there are alternatives, sort of a comparative gold standard where you can look at another data source and try and compare and assume sort of what's truth from that, as well as silver standards, this idea of using other computational methods to sort of estimate or predict that. So there's a range of options there to consider. Data quality is absolutely huge and central, and I know Michael Kahn gave a wonderful talk on that as well. So I will just quickly say that sort of our thinking was that a data quality assessment should accompany the phenotype validation. So an understanding of what the data look like in a number of dimensions is really important to understand, the metrics that you're seeing from the phenotype validation. And part of this might include a workflow assessment. No one's meant to read these words. It's just sort of illustrative figure, but understanding, in different healthcare systems where codes happen and where they're restricted, it's really important as you look at the data. So these are things that we have recommended and I think are important to look at as you're looking at multi-site studies and design. I'll just highlight there's lots of dimensions of data quality, and I know you've had a previous talk on that, but completeness, accuracy, and consistency are the big ones that we identified, and there's several ways to operationalize those, but they're really important. And data quality assessment as a formal tool, it's really very important. So again, now we've done validation. So let's think about reporting and publishing these other phases of reuse. So in terms of this, we really, again, as you're reporting phenotype definition, really the purpose and context is really important to the next user, to the person that is reviewing it or considering reuse. And then the specifications of what is needed data-wise, and then the validation methods and results and experience, as people learn from this or what they find in terms of implementing it or the results. It would be great to have some sort of ecosystem where we begin to share some of this. So to reuse phenotypes at scale, we need a platform to search and browse them. I showed you a few, but there's more features that are needed there, and then there needs to be a way to get people to put things there. And so incentives to use these and to reuse phenotype definitions, I think, will be critical and areas of potential high impact activity. Just quickly, I'll highlight that people have thought about this. There's an excellent review article by Martin Chapman with representatives from really all the phenotyping efforts that I've mentioned and others that sort of came together to decide what's a desiderata, like what do we need for a library of phenotype definitions that can enable reuse. So they have a lot of requirements listed about modeling and logging, like supporting versions, how to implement, what kinds of information do people need, and validation. And I'll just highlight that this article suggests that there should be tools to help people look at existing definition and validate it in a data environment, such as what Odyssey is doing with their tools, but that we can enable feedback and really enable this piece of the process, which is so huge. And then other sort of technical areas about making these things available. So I think this is what's needed, and how do we get there? So a few opportunities as I wrap up quickly here. We're moving towards standards. Right now, we only have a few data types, so most of the phenotypes you see build on those. So a few data types that are truly standardized, right? So the ICD-10-CM is uniformly adopted, so we see a lot of definitions on that. We have standards for lab data. There's still some challenges with that. Same with medications. But as we move towards this new standard called FHIR, our healthit.gov, our Office of the National Coordinator for Health IT, is rolling out standards of core data elements that will use this emerging standard and begin to be standardized in EHRs at the start. And so that's going to really enable the kinds of research that we could do from EHRs downstream, right, without adding additional data collection burden in theory. The FHIR resource, the HL7 FHIR also has resource for questionnaires. So this is a standard that can really facilitate getting patient-reported data and instruments that are sort of disease specific, but getting those into our EHRs and available for research. So a standard representation, which we don't have now. So that is the FDA is also realizing and trying to provide good guidance on how important real world data is for regulatory decision making, for understanding safety of drugs and making decisions around that. And so they're specifying that we need for computable phenotypes that metadata, including supporting information on many of these features I just mentioned. And so there's a push now and to do this, and lots of people are getting involved in seeing the need to be very explicit and to enable transparency and reproducibility around these phenotype definitions. And so all this is sort of the merging and the evolution of EHRs and standards and our increasing use of EHR data from lots of things has sort of made us sort of shift our paradigm about EHRs and what's a secondary user versus a primary user. And so we're in a position where we're seeing important things being standardized in the EHR, but that needs to happen in the bigger context. So there still is a phenomenon of burnout, of people or clinicians are frustrated with EHRs. They're tired. There's a burden of data collection that's not sustainable. So the solution is not adding more elements, but being thoughtful about the elements that we're including in EHRs. And so the AMIA, there's a reducing documentation burden coalition that is, again, focused on how can we reduce the documentation but increase the value of what we're getting. So there's a lot going on that, offers me every optimism and hope that EHRs will increasingly be ready to support the kinds of research that we want to do with pragmatic clinical trials or in the LeaRRn network. With that, we'll just point you for resources to our Rethinking Clinical Trials textbook. It's an online living textbook. We have a chapter on electronic health records and computable phenotyping, and then a general one on using electronic health record data in pragmatic clinical trials. So there's a wealth of information, very, very readable too. So I'll direct you there, and there's other resources on my resource page, and I'll look forward to talking now about implications for the LeaRRn network. So thank you for having me, and I look forward to some good questions and discussion.